Good afternoon. Today is Wednesday, June 14th, 2023 at 1 o'clock Arizona time. Welcome to a web briefing of the Arizona Advisory Committee to the U.S. Commission on Civil Rights. I'd like to remind everyone that this is a public meeting and it is being recorded. Present on today's call are staff of the Commission and members of the Arizona Advisory Committee. There may also be members of the public who will be invited to speak during the public comment period of today's briefing. My name is Leslie Ross, and I am the chair for the Arizona Advisory Committee. I will now take roll call. Committee members, if you are joining by phone, you may press star six to unmute yourself, and star 6 to place your phone back on mute. Angela Banks.
Present.
Rebecca Browder.
Present.
Tessa Dysart.
Present.
Patty Ferguson Boney.
Present.
David Kim.
Present.
Teresa Rosas.
Present.
Jonathan Rose.
I do see him on the line. I'm not sure if he's having issues with mute and unmute.
Okay, I thought I saw him on the line too. Christina Sandifer.
Present.
Beverly Traver. Heather Whiteman Runsom. Henry Whitmer.
Present.
Eric Yordy.
Present.
We have a quorum present and we'll proceed with the meeting. Also present are commission staff, Kayla Fajota, our designated federal officer, and Angelica Trevino, our support specialist. The U.S. Commission on Civil Rights is an independent, bipartisan agency of the federal government charged with studying discrimination or denial of equal protection of the laws because of race, color, religion, sex, age, disability, national origin, or in the administration of justice. An advisory committee to the commission has been established in each of the 50 states and the District of Columbia, as well as the 5 territories and commonwealths. They are made up of responsible persons who serve without compensation to advise the commission on relevant information concerning their respective states. The Arizona Advisory Committee voted to investigate the topic, racial and ethnic disparities in pediatric healthcare in Arizona. Today is the first of several web briefings that the committee will hold throughout the next few months. If you would like to subscribe to our email newsletters, please contact our support specialist at atrevino@usccr.gov. Today, we will be hearing from researchers, academics, and practitioners whose work relates to the committee's chosen topic. Panelists will be invited to provide their initial remarks shortly, and each is limited to around 15 minutes. After all the panelists have spoken, advisory committee members will have an opportunity to ask questions to the panelists. This Q&A is reserved for committee members only. After the committee Q&A, there will be a public comment period where members of the public will be given an opportunity to share their perspective and opinions on the topic. If you are a member of the public and have joined online, commission staff will be messaging you to see if you would like to comment. Please keep an eye on the chat. For the members of the public who are joined on the phone with audio only, you will be able to indicate with your keypad when we reach that point in the agenda if you would like to comment. The briefing will conclude after the public comment period around 3:00 p.m. Arizona time. If you are not able to share your full remarks today, you're welcome to email them to atrevino@usccr.gov for inclusion in the committee's proceeding. The committee will then move into conducting committee business related to planning future briefings. If you are a panelist or a member of the public, you may choose to stay on the call if you wish, as all of the advisory committee meetings are open to the public. Before we move into panelist presentations, I will go over some key ground rules for the briefing. This is a public meeting, open to the general public. I want to remind everyone again that this meeting is being recorded and will be transcribed for the public record. I ask that you please state your name when speaking to assist with the transcription. All attendees should mute their devices when not speaking in order to capture high-quality audio for the recording. Commission staff will also monitor sound output and will mute devices of participants who have background noise. To view the closed captioning for today's briefing, click the CC icon in the lower left corner of your screen. Though some of the statements made today might be controversial, we want to ensure that all invited guests feel welcomed and do not defame or degrade any person or any organization. As the acting chair of today's meeting, I reserve the privilege to cut short any statements that are irrelevant to the issue at hand or are defamatory or degrading. Any persons or organizations that feel defamed or degraded by statements made in these proceedings should contact commission staff during the meeting so that we can provide a chance for public response. Alternatively, such persons or organizations can file written statements for inclusion in the proceedings. I urge all persons making presentations to be judicious in their statements and remain on topic. The Arizona Advisory Committee appreciates the willingness of all participants to share their views and experiences with this committee. As we move toward the panelist presentation, I would like to first introduce today's panelists. We are joined by Dr. Daniel Derksen, Professor of Public Health, Medicine and Nursing, and Associate Vice President for the Health Equity Outreach and Interprofessional Activities at the University of Arizona. Amanda Hagerman, Policy Analyst at the Goldwater Institute, and Dr. Helene Felman, Division Chief of General Pediatrics, Clinical Associate Professor of Pediatrics, and Advocacy Director of the Pediatric Residency Program for Banner, University Medical Center, and University of Arizona, Tucson. With that, I would like to invite our first panelist, Dr. Derksen, to present.
Great. Thank you, everyone, for joining us today. What I'd like to do is run through some of the disparities that we see in Arizona related to healthcare access, but also some of the social vulnerabilities that we see in populations, especially younger populations. My training is in family medicine. So, over the years, I've treated many patients, including pediatric patients. So that also kind of colors my view of how things are delivered. Let's see here. I'm not seeing. Oh, there we go. Let me go back one. So Arizona, for those of you that aren't as familiar perhaps with the state's demographics, we're about 14th in total population of the states. We have 7.4 million of that population. A little less than 2.5 million are covered by our state's Medicaid program that we call the Arizona Healthcare Cost Containment System, or ACCESS. And within that group is a children's health insurance program that we call PIDSCare in Arizona. We only have 15 counties in the state, so our counties tend to cover very large geographic areas. Coconino County, for example, which surrounds Flagstaff, is the second largest county in landmass in the United States. There's one county in California that beats out Coconino for the size. And if you weighed it up against some of the eastern states, we'd encompass many of the states that are initialed up there. Over the last 10 years, we've been a top 5 state in population growth, and Phoenix vies with San Antonio, I think, for #1 major city in population growth. So we've experienced very rapid population growth. We've grown over the last 20 years about 44% in population, over 2 million new Arizonans over those 20 years. And that compares that 44% population growth to 18% population growth across the United States. And one of the things that's happened because we have grown so rapidly is that our health workforce supply hasn't really kept up with our population demand. And so compared to other states, we rank 42nd in the number of primary care physicians, and that would include physicians like me in family medicine, but also general pediatrics, general internal medicine. Those are the ones generally that folks think of when they think of primary care. One of our biggest rate limiting factors as far as addressing the health workforce shortages we have in Arizona, especially in rural areas, is that we don't have enough residency slots. So after going to osteopathic or medical school, we don't have enough residency spots for folks to go into. So a lot of our graduates in Arizona have to go outside the state for their residency training, what we call graduate medical education. And what happens when they leave the state is 75% of them don't return. So right now we rank 37th in the number of resident full-time equivalents that we have in graduate medical education. We have 24 per 100,000 compared to the United States as a whole at 44. If we're going to address our health workforce shortages and keep more of our own graduates here and really address unmet need, we're going to have to expand our residency slots. We're also short, not only in primary care, where we rank very poorly. We should rank in one of the top states given our population, but we're 42nd in primary care physicians. We also rank very low in the total number of physicians, so across the specialties, including the pediatric specialties. And once you get outside of our major metropolitan counties, Maricopa County around Phoenix and the Greater Valley, Pima County and Tucson, it can be very difficult to obtain specialty services, and that's true for pediatric specialties. And we also noticed, especially during the pandemic, that we're pretty short on nurses as well. And we saw this, a single nurse in an ICU in a small hospital in a rural area could mean the difference being able to accept patients into the intensive care unit versus having to divert them to another place that still had the nursing workforce. And we're working on some of those things at the policy area, but it's not just the physician workforce that's one of our challenges. It's also our other health professions, including nursing. And then I really want to emphasize this one. Our health disparities as far as access to care and health professional shortage areas is particularly difficult in certain counties. And we have 22 federally recognized tribes in Arizona. The tribal areas in our state comprise almost a quarter of our landmass, and we're the 6th largest state in landmass. So our reservations are quite large, including the largest in the United States, the Navajo Nation, which encompasses a significant portion of Northeast Arizona, but also goes into New Mexico and a little bit into Utah. And these areas have some of the highest, and this is a federal designation, we have some of the highest scores in health professional shortage areas. And I put the criteria on this slide. The highest score you can get is 25, and many of our tribal communities experience very high numbers, 20 you see in many of them: San Carlos Apache, Gila River Indian Community, Tohono O'odham, Navajo, the Apache Reservation and the Hopi Reservation. And I included some of the number of primary care physicians were short as far as the full-time equivalent. So this is distributed amongst certain rural counties and then certain populations disproportionately. And so the health professional shortage areas, we have about 238. It's not just rural health profession shortage areas for primary care, but we also see similar numbers and similar very high scores for lack of access to dental services, particularly important in a pediatric population, and also behavioral health. So there's 3 federal designations. The one I've listed here is for primary care. It would look very similar for oral health access and behavioral health access. Unfortunately, despite our shortages and despite some of our challenges, we actually decreased the number of residency slots in primary care over 3 years from 2016 to 2019 in Arizona. And so this has widened the gap in access to care because those pathways into practice depend on us having enough residency slots, because those folks, especially if they do their undergraduate, their medical school or osteopathic school here, and then do their residency, 75% of those stay. We just don't have enough residency slots to keep our graduates in the state and then go into practice here. So, and this arrays that data by county. Again, we have very large counties. These cover very large geographic areas. So this kind of puts the context of how many FTEs we're short in primary care physicians in each of our counties. And then what percent of the population, the darker areas, really look at the percent of the population living in a health professional shortage area. If we don't address our primary care physician shortage, which is estimated by the Health Resources Service Administration at about 667 full-time equivalents, by 2030, we'll be almost 2,000 primary care physicians short. So access to pediatric services depends on a robust, adequate number of primary care physicians, general pediatricians, family medicine, includes nurse practitioners and physician assistants. Those all contribute to our ability to take care of the primary preventive, but also the special needs of our pediatric populations in the state. I emphasized this a little bit before, but this shows it graphically where we stand in the number of residency slots, graduate medical education. We're at 28.5 per 100,000 compared to the United States at 43.8. Where we should be as a population is commensurate with our 14th in population. To get there, we would need 1,100 residency slots today to get to where we should be for our population. So it can't just be all specialty residencies, which academic tertiary care centers in Phoenix and Tucson tend to train most of. For the new residency slots we need, 2/3 of those should be in primary care so that we make sure we have enough primary care physicians and specialty physicians to meet our need. So this has to be a balanced approach. Medicaid is a critical component of how we subsidize graduate medical education. Unlike Medicare GME, graduate medical education, which was capped in 1997, and this is part of the challenge we have, is that Medicare capped the number of residency slots that would be subsidized by the Medicare program. And states like ours that have grown very rapidly haven't been able to keep up because we're capped at a level and then our population has gone up dramatically over the last 20 years. So we've gotten further and further behind without a pathway into practice with enough slots. But our Medicaid program offers a partial solution to that. There's no cap on the Medicaid graduate medical education. However, the residency programs themselves often have to come up with a non-federal match required to draw those federal dollars. It's a very favorable match for Arizona because our per capita income is a little lower. So the federal government ends up paying for every dollar we put in state funding for the Medicaid program, we draw almost $3 in federal Medicaid assistance percentage. So the Medicaid number of residency slots that it's helped subsidize is listed there. But the challenge is, especially if we want to have more residency slots where they're most needed, let's say in rural and tribal communities along our US-Mexico border, for example, we need to help cover that non-federal match, really what would normally be the state share, so that we can have an adequate number of residency slots given our population. So in addition to health professional shortage area as one metric we would look at to determine to target, hopefully, our interventions for how we might address unmet need in pediatric and other populations, I like to use the Social Vulnerability Index. The CDC, the Centers for Disease Control and Prevention, just updated their numbers with 2020 data. But these are based on census data criteria. There's something like 15 of those, and you can see them. These we often refer to as the social determinants of health. And these are the underpinning of why certain populations are more vulnerable to things like a pandemic, while we might see higher transmission rate or morbidity and mortality for certain populations. Some of them have to do with socioeconomic status. Our rural areas tend to be lower in per capita income. They also tend to have more chronic disease. they also tend to have less access to services, in our health professional shortage areas is a demonstration of that. Transportation can be a huge issue. And then even if there is some clinics and hospitals within a reasonable geographic area, sometimes Medicaid isn't accepted because it tends to pay less even than what Medicare pays. So an obstacle to getting care is often, hey, if you're way too busy as a health provider, and then you're asked to discount the services you have, or you have to shoulder a lot of charity care or uncompensated care, as is often the case in our rural areas. These can be challenges to access necessary services. We tend to do a map, and this is available on our Center for Rural Health website, of where our safety net tends to be. This is a slide that we do for the rural areas, our more rural counties. Remember, only 15 counties. The biggest metropolitan ones are Maricopa and Pima, Phoenix, and the Greater Valley, Tucson. But our 13 other counties have significant health profession shortage areas. There's 7, these are all federal designations. So we have 17 critical access hospitals. Those tend to be the 25 beds or less, 35 miles or more. So this is often the place where people go in these very remote rural and frontier areas. We have 45 rural health clinics. Most of those are associated with the critical access hospitals, but there are independent rural health clinics that are really increasing in number in rural areas, which is a good thing. We have 23 community health center systems. You may have heard the term federally qualified health centers, or FQHCs. Well, there's 23 of those community health center systems that operate in over 200 sites across the area. They're not only in rural, they're also in urban underserved areas. And this is a critical strands in our safety net in our populations, especially for pediatrics, because they tend to see a very large number, a disproportionate share of our Medicaid population, many of whom are children. We also have in Arizona, which is different than other states, a lot of not only Indian Health Service clinics and hospitals. We have 16 of those. We have 31 tribal operated. So tribal communities have the option of having Indian Health Service do their clinics and hospital, or doing their own, what's called Public Law 638 self-determination. And we have many tribal operated sites. So this tends to be the rural health safety net. We also have rural hospitals, a little larger in size than the critical access hospital, and of course, private practices. This is a busy slide, but I wanted to just point out 2 of our counties. Apache County, which is comprised of about 73% American Indian population. In this county, if you look at the social vulnerability index, so the highest number you can get in the social vulnerability index that CDC does is 1.0. And look at some of our counties, they're like 0.9885 in Apache County. Navajo, 0.9955, some of the highest social vulnerability indexes you might see. When you combine the assessment of social vulnerability index and add the health professional shortage areas, it was a very good predictor of the disparities we see in health outcomes, whether it's related to a pandemic, or it's related to access to care, or it's related to untreated diseases that you might see in a pediatric or a geriatric population. Another county along the US-Mexico border, if you look at Santa Cruz, 83% Hispanic Latino population, very high social vulnerability index, very high health professional shortage areas. So these are metrics that we can use to help gauge where our intervention should be and where we really need to spend more time and funding really to address some of the disparities. But there's good news, and I just want to spend a minute on this because this was in March in the Centers for Disease Control report, where we look at disparities in this case in COVID vaccination. And one thing that really jumped out at me was that in every state in the United States, the urban vaccination rate for COVID-19 was higher than rural. And in Arizona, we were the only state where rural was higher than urban. So we had devastating consequences in terms of morbidity and mortality in those counties that I just mentioned, Once vaccines were available, we had some wonderful examples, some scenarios to look at of how to run a successful campaign to really address an issue. Navajo Nation is often brought up as an example, and rightfully so. They did an incredible job of getting vaccines out to some of the most rural and remote areas in our state. We saw this also in the other county I mentioned, Santa Cruz County, and around Nogales, that they were very effective working with their county health department, with the state, the Arizona Department of Health Services, and then local providers to get the things out that needed to be done. So we can do a better job in this. And I think one of the better examples we can look at as far as workforce is teaching health centers. We know that in programs that use a teaching health center model, that 80% of the graduates of those residency programs remain in primary care, more than half of which remain in health professional shortage areas to practice. Their total budget last year was $155 million. Compare that to the $25 billion a year we subsidize residency programs, 95% of which are in urban tertiary care hospitals. If we were to better balance the investment in where we need health professional training to occur, I suspect that we would be able to address some of the most intractable problems that we've had in access to high quality care, including in pediatrics. So we've done a good job trying to address these issues in Arizona. We just got a $5 million appropriation from the legislature budget that was just approved and signed by the governor to really help rural areas, federally qualified health centers, Indian health service sites, tribal operated sites, rural health clinics, really stand new primary care residency programs. And my hope and my optimism is that we can get more folks trained in pediatrics out to the areas where most needed. And one of the ways to do that is to do it in the sites that are most needed and stay connected afterwards with continuing medical education and others. We have a wonderful area health education center system in Arizona. We just added a 6th AHEC regional center, which is called the American Indian Health AHEC Regional Center. They just got started in September. So they're going to be helping us with these vast areas and in tribal communities around the state to make sure that we train our own. We also do more of the training and hopefully get more people practicing in these areas of need. So with that, I'll conclude my comments. These slides, feel free to make available to the folks both on the call, but also publicly. And thank you for the opportunity to share some of this information with you today.
Thank you, Dr. Derksen. I appreciate it. For the members of the committee, I request that you, if you have any questions, that you just hold on to those questions until it is our time for our Q&A. And now I would like to invite Amanda Hagerman.
Yes, thank you. Okay, good afternoon, everyone. Oops. Okay, so my name is Amanda Hagerman. I'm going to minimize this. And I'm a policy analyst here at the Goldwater Institute, but also I worked for several years and still do contract as a newborn and childhood epidemiologist at Iowa Department of Health and Human Services. And what that allowed me to do was I had access to every single pediatric data set and program that was done at a state level. So my two objectives today is, one, I want to talk about how important it is to deep dive into data. And two, I'm going to talk about what data sets are available at a state level that allow you to get more granular and create those tailored interventions. So health equity, a lot of us are familiar with this, but what I really wanted to point out is public health organizations want to address inequities are extremely important, but truthfully, few have done the research that is required for it, particularly for state programming. So some issues with typical state data evaluation. I wanted to give you guys some context. So first off, it's based on, a lot of times based on national data. Most of the programming that is done on the state level is informed by national evaluation. So a lot of times if you see CDC or HRSA put out that a group is behind, a lot of people will think their group is behind, that same group is behind for them. Also extremely aggregate. The
Amanda, it looks like you're having some technical
Intermittent.
difficulties. Okay,
Oh, can you guys hear me okay?
your video and audio is frozen for a moment.
Yeah, I
Oh.
think we lost about 10 seconds, Amanda.
Okay.
Amanda, yeah.
Thank you so much. It says my internet connection's unstable. How is that though? Is that better?
Yes,
Okay, excellent. So another big issue is it's extremely aggregate. And I kind of mentioned there's no stratification by geographic region. So if you look at race and ethnicity a lot, they don't go down to city level or zip code, which, as we know, where you reside and where you travel for care are major determinants of outcomes, okay? And then finally, there's no ranking or strategy that allows for tailored interventions and even deeper qualitative exploration to identify what is keeping populations behind. And I wanted to give an example. This is the proportion of children 1 to 2 years of age with elevated blood lead levels by statistical area. And again, I'm giving an Iowa example here, but I want to make a point. Usually when you see charts like this, you just see race and ethnicity for a state. That's too aggregate. Why? Because all these populations have different stories and their signal is going to be lost if you group them all together. So you can see here, I broke it out by statistical areas. Arizona is probably going to have more of them, but for this example, metropolitan is anything with an urban core of greater than 50,000. Micropolitan is anything 10 to 50,000 and non-core is outside that. In less than 10,000. So just to give you an example, if we look at the American Indian and Alaska Native population, we can see that those that reside in metropolitan areas have extremely high elevated blood lead levels compared to those that are in non-metro. You have to, again, these are way different stories, right? When you look at all the other populations, it's a different story. Their non-metro populations have higher elevated blood lead levels, but if you had grouped them together, you wouldn't see the differences. And my last point with this chart is, again, look at that American Indian Alaska Native group with the metropolitan that's saying about 20% of those kids at elevated blood lead levels. Something to keep in mind for state data evaluation. It doesn't mean that all metropolitan American Indian children have high elevated blood lead levels. Probably there's a zip code or city that's pulling or skewing those kids. And that's our job. We have to go find out where it is. Okay, so implications of not using local and granular data. Truthfully, it's a waste of resources. It causes unintentional harm, and you're going to have no improvement in your key performance indicators or your benchmarks for the state. And one thing I've learned working as an epidemiologist is every program and health system have different populations that are behind. Our job is to find those communities. So a little bit before I dive into the programs that have data, this is framework for pediatric data evaluation. And the reason why I'm harping on this is because I already know you guys will have to do more data digging. Right now, there's not a lot of data available at a granular level, and you'll see what I mean. So one, choose the programs as data set you want to analyze and ensure key variables are present. I can't tell you how many times people come to the state, ask for a data sharing agreement, and they realize there's no geographic variables there to analyze where the child resides, where the parent resides, or where they're traveling for care. So that's very critical. Second, most of the times when you are analyzing inequities, you don't want to just look at, you want to look at the health outcome, and you also want to look at, did they receive that healthcare delivery? There's two aspects, right? So did they get that diagnostic test? Third, disaggregate the data, big to small. A lot of state evaluation does not do this, and we'll go over that. It's very critical. And then explore variables of interest. Oh. Okay. Explore variables of interest. What may be a predictor for one group may not be the other. The speaker before me was speaking a little bit on the social vulnerability index. You know, for example, single parent households, that could be a predictor for one population for access to care. It may not be for the other. And that's why statistical models can be a bit misleading if you don't dig down in those populations. And finally, rank and prioritize your populations of interest to make sure it's targeted and it's effective. So here, I've worked with several pediatric programs, and what I try to think in mind for you is one, which ones have good data sets that you can make an impact, right? The second thing is, why did I choose early childhood? Especially, I know you guys are doing pediatric 0 to 18, but here's the thing. A lot of times you're limited on the time that you get to research. So I thought, what would be the most impactful? Well, 0 to 5. Why? Because 90% of brain development occurs during that time. Secondly, we know that interventions during this time impact education attainment, workforce participation, and really have lifelong implications. So one of my favorite data sets that's very underutilized, and people have no idea how rich it is to look at child outcomes and look at their parent characteristics and healthcare characteristics, is something called EDDI. I don't know if you guys are familiar with this. So early hearing detection intervention, you guys have the AZ EDDI program, and you can study so many congenital conditions in that, but one in particular is the most common congenital condition, is deaf and hard of hearing. So overall, you're looking about 2 to 3 per 1,000 children, live births, but in certain populations, it can be 30 to 40. And what's fascinating, apart from deaf and hard of hearing, but a lot of congenital conditions in that data set, they follow a socioeconomic gradient. So when you look at children who are deaf or hard of hearing, you see high rates of kids on Medicaid, closer to the poverty level, long NICU stays, so long neonatal intensive care unit stays, et cetera. And just to give a little bit of background on this program, every child, pretty much about 99% in the state, when they're born, they receive a hearing screen. And if they do not pass, they need a diagnostic by 3 months of age. And you can imagine, why is that so important? Because if, for example, if a parent wanted to fit their child with a cochlear implant to hear them speak, if they don't hear words, their parent's voice by an early age, it can really impact speech development and have implications long-term. Secondly, Ages and Stages Questionnaire, ASQ. This tool is used to screen communication, fine motor, gross motor, and other developmental milestones. If a condition is identified, a lot of times this child will be linked to the First Things First program. Providers can link them to. So the First Things First supports health providers in the earlier detection of social and emotional development delays in children ages birth to 5. Truly a bridge between primary care and public health services. And finally, I wanted to discuss childhood-led. Childhood-led, your numbers may look low in Arizona. I was looking at that, but it's because testing coverage is extremely low. And children at ages 1 to 2 are most at risk because you can think about it, they're more likely to be on the ground. If you're in homes pre-1978, the paint can be toxic. And thirdly, I wanted to say that CDC just changed their benchmark from the cutoff for high elevated blood lead levels went from 5 to 3.5, which means your populations of children with high blood lead levels probably nearly doubled, truthfully. So these are just something to keep in mind. But EDDI, I really think it is going to be very powerful for you all. And I'm going to give a little bit of reasons why. So one, this data set is rich. You know, it allows you to study every single birth in the state. So home birth, hospital birth, you think about that wealth of information. And it looks at deaf and hard of hearing, cytomegalovirus, CMV, which we know is the most common viral and congenital infection. And again, follows a socioeconomic gradient. When you look at women who are more likely to have CMV when they give birth, certain populations are much higher. As well as you can look at kids that had parents that had STIs when they were born. So those are some of the outcomes. And then again, many of these risk factors for these congenital birth outcomes follow a socioeconomic gradient. So low birth weight, preterm delivery, maternal infections, again, long NICU stays. These are important things to look at. And the other big thing that I love with this data set is, apart from child characteristics, you can look at maternal, which is so linked to child outcomes, because from 0 to 5, who's taking them to the appointment? It's the mom. Or that if it's not the mom, it's the single parent in that household, right? So you want to look, they collect things like prenatal care, single parent, age of the parent, et cetera, which we know are determinants for accessibility. And then finally, one of my favorites that is rarely done is looking at healthcare delivery factors. The speaker before me, discussed what the shortage is for pediatric providers, and it's so true. And a lot of times when I do my social epidemiology analyses, I find a lot of issues happening on that healthcare delivery. And it's really important to see not only, like I said, where these kids reside, where a lot of times where they're born dictates a lot of follow-up care they get, and then where they're going for care. And then finally, what does this allow you to do? It creates tailored interventions and it allows you to make a difference. And a lot of times if you look in the state, certain cities or certain groups that are left behind, let's say in one zip code, a lot of them are going to the same places for care. So you can hit a lot of birds with one stone, right? So the last thing I wanted to point out about Eddie. So you get every birth in the state, but the population you want to focus on in that data set is the infants who do not pass a hearing screen. They're unique. They have higher percentages of single parent households, young mothers. Overall, when you look at families of children who are deaf or hard of hearing, they're more likely to report poor health status, live closer to the poverty level, single parent households, and recipients of Medicaid. So yeah, here is a table that I wrote all the programs I discussed. I am focusing on Eddie because I think it's the data set you guys need to take a look at. And I put the key KPIs, key performance indicators, your variables of interest. If you do a data sharing agreement, you might want to look at those, and then some notes. One of the most powerful KPIs that I highly recommend in the Eddie realm is among those that did not pass a hearing screen that need a diagnostic. I talked about how important that is. You should look at the percentage that did not receive a diagnostic assessment to see if they're deaf and hard of hearing. CDC calls it lost to follow-up. They're lost. They never received that diagnostic. That group, social determinants of health, are magnified beyond means. I can't even begin to explain. And in the state of Iowa, and I haven't looked at AZ data, but infants whose mothers identified as Black or African American and lived in metro areas, about 35% were lost after a hearing screen that they did not pass. So they weren't diagnosed if they had deaf and hard of hearing. That has a lot of implications. So just to give you kind of an idea, you guys can take a look at this later. It's a lot of info, but just gives you a little bit of groundwork. And then back to some of my recommendations with working with data. This is the biggest issue I have with public health programming. They are so aggregate. You'll see urban versus rural, or you'll just see state level race and ethnicity groups. That is going to really we're going to be doing blanket programming. Okay. So you just want to break it down. And in Arizona, in a place where counties are so big, you need to bring it all the way down to the city level, at least minimum, and maybe even lower than that. And then break out, look at your race and ethnicity groups. How does a mom who identifies as Latinx/Hispanic that lives in the Phoenix metro compare to one that's south of Tucson? They're going to have, I say mothers because those are the ones that are taking the kids, right? But we can use child too. They're going to have very different outcomes. So once you identify certain groups by race and ethnicity, you just have to keep diving down. And again, look at not only where they reside, but where are they going for care? And then once you identify the locations and groups with higher proportions of the desired health outcome, you can rank the populations to target. And I don't want to bore you guys. I know it's a lot of information. I'm almost done, but this is just a step that you want to do when you rank data. Most people do not rank data in the sense of, this is, if you want to make a dent in your key performance indicators and make an impact, this is what you do. So one, you rank by frequency of desired outcome. That desired outcome means the outcome you're trying to improve. So for example, you'd rank the data from, let's say if you were doing cities that contributed the most amount of infants who do not receive a diagnosis, for example, for staying in the realm of Eddie, to the least. And then secondly, you'd prioritize those high proportions of desired outcomes. So for example, let's say Phoenix, of course, by sheer size, it contributes, let's say 1,000 kids that did not get a diagnosis. But honestly, maybe if you look at their proportion within the city of Phoenix, maybe only 13% had a late diagnosis or did not get a diagnosis. And if we look at the next city, let's say Tucson, just an example, maybe they contribute the second highest amount of that desired outcome, but their proportion could be 40%. So guess where we're going to be targeting? We'll target Tucson. This is an example. And we're going to look at which race and ethnicity groups are behind, where they're at, and where they're traveling for care. We want to get to that hospital level, especially like in the realm of Eddie. You want to see where these kids are being born at, where they're going for care, because that's really where you make a difference. So overall, my last slide for you guys, thanks for hanging on. It's a lot of stuff. It's become the norm to aggregate population data. CDC does it, and that's okay. You know, that they want to show us trends on a national level. They're not doing state programming, but we're missing the true stories of each unique community. You know, no matter what race and ethnicity group, where you live, you're going to have differences within and between communities. We must find out where pediatric populations are behind and identify where they reside and travel for care. And then identifying the who and where allows you to identify the how and why. So if you guys have any questions on ranking or the EDDI data as well, let me know, and thanks for your time.
Thank you very much for participating today. I would now like to invite Dr. Felman.
Hi, everybody. First of all, thank you so much for having me. I'm honored to be included on this list of incredible panelists. So let me just get started. First, I'm going to try to focus on a couple of different things. Fortunately, it doesn't overlap too much with my prior panelists, but to take a quick overview of the excellent project proposal that was done by the advisory committee, and just kind of graphically show some of the discrepancies that we see here in the state of Arizona with respect to access to care, as well as access to subspecialty care. So once again, I'm the Division Chief of General Pediatrics at the University of Arizona, also a clinical associate professor and the advocacy director of the Pediatric residency program. And I have to say that these views are my own and not representative of the University of Arizona, the state of Arizona, or the Board of Regents of Arizona. Okay, so are there racial or ethnic disparities in the provision and access of pediatric health care in Arizona? That was one of the questions that I think that this committee wanted to pose today. And the answer is yes. Oh, whoops, too far. So just to reflect, this is the percentage of children that do not have health insurance in the state of Arizona. You can see that we are 48th of 51 within the country. So we're ranked 48th across the country. 8.5% do not have health insurance here in Arizona. And that's much lower than the national average, which is this yellow line. As a comparison, California, which is not too far from us, only has 3.5% uninsured and is ranked 14th out of 51st. And why does this matter? As Dr. Derksen kind of briefly explained, the Arizona health cost containment system, or Medicaid here in the state, provides a lot of the health insurance for our underrepresented minorities in the state. And you can see that here, the rates of uninsured in Arizona and underrepresented minorities are much higher than those white children. And we see the same goes for Hispanic and Latinx populations, that the Hispanic Latinx populations have much higher uninsured rates versus non-Hispanic and Latinos. Okay, and you can see that here in the state, fortunately, we, of the children that are eligible to receive Medicaid, they're very, like, most of the people who are eligible are getting it. So I'll go through this in a couple of slides, but what are some opportunities for improvement within our state system? And it's increasing our enrollment opportunities. So increasing the median income of those that are eligible for access or Medicaid will help reduce this burden within our state and decrease that number of uninsured. You can see that in Arizona, we only qualify children under 19 if they're 205% of the federal poverty level, while as the US median for all Medicaid programs is 255. So the eligibility threshold is much lower in our state, thereby not including some very vulnerable children. Okay, now I'm going to switch gears a little bit. Dr. Derksen started to talk about our pediatric, or just the workforce in general. This is an example from the American Academy of Pediatrics about the state of Arizona and our need to care for children with pediatric subspecialty needs. So I'm a general pediatrician. I would see your child in the office, but say I diagnosed a rheumatologic disorder, which is very rare, but is a possibility. There are very few pediatric rheumatologists in the state, and someone with juvenile arthritis or lupus would need to drive as far as 246 miles to receive that care. And that is so challenging for a family of means. But as we all know and have heard, children who are part of underrepresented minorities are much more likely to have issues with transportation. And issues getting time off work to be able to get to that appointment. But 246 miles, that is a long way to go. Another example, see. So let's consider a child with suspected autism. So if I see a child in my office and the parents are concerned about a speech delay and potential autism, the wait times for behavioral care or developmental care is astronomical across the country, but exacerbated here in the state. So the wait time to get in, if I refer that patient, is anywhere from 6 to 12 months. And then furthermore, the driving distance to that appointment is even more than seeing that rheumatologist. So it's going to be 248 miles to travel on average. And then once they get the diagnosis, receiving those therapies to help reduce those reduce the effects of autism in the long run, the wait time is another 4 to 6 months, just because we not only do we have a dearth of physicians and nurses, but we also have a dearth of subspecialty therapy providers in this state. And then the little box below claims that even though autism spectrum disorders is very, the prevalence is much lower in Hispanic and Black, or I'm sorry, is about 16% lower in Hispanic children compared to white and Black children, which suggests that more Hispanic children with autism are not being identified. And I wonder, and I've seen this, there are some cultural differences in patients accessing care, and it's hard to kind of drill down why they may not be so comfortable bringing things up with pediatricians, but that is one other area of opportunity to figure out, like, why are Hispanic children or Latinx children not identified as often as white or Black children? So what can be done? In terms of improving access to healthcare insurance, I think it's pretty clear that in states that have continuous 12-month coverage, they have improved rates. So here in the state of Arizona, you have to reapply if your income changes. And in other states like California, they have continuous 12-month enrollment. So I wonder if that's one of the other differences between us and California. We also have a waiting period of 90 days, whereas in other states, if you apply for access or Medicaid, you immediately get access to that insurance, versus here in Arizona where you have to wait 90 days. And 90 days is a long time if you don't have insurance. And then, as I mentioned, for the access to our subspecialists, we need to improve potentially loan repayment programs targeting underrepresented areas within Arizona. Dr. Derksen mentioned that health provider shortage area that determines whether or not someone can get potentially loan repayment. And I know for me personally, I was very fortunate that in my first job outside of residency was in a health professional shortage area at a federally qualified healthcare center. And that really reduced the burden and helped me really want to go into primary care. I know that many people choose subspecialties or to stay in urban areas because it's easier to make more money. And a lot of people come out of medical school with huge amounts of debt. So to provide a greater workforce, providing additional loan repayment programs, targeting those areas is another way of increasing access, not only to subspecialties within pediatrics, but just improving the pediatric workforce as well. And then we can also evaluate enhancing funding for subspecialty outreach clinics to those rural areas. So those are a couple of suggestions. And then perhaps consider funding screening tools for racism and to document perceived racial biases. There's a few that are in the literature, but that is something that's really hard to find other than these very small studies, because what we think may be an issue might not be perceived as one to those patients. And then consider a means of self-identification marker versus what someone's automatically assigned to potentially reduce those biases as well. And then finally, I'm very fortunate to be a part of a wonderful organization, the American Academy of Pediatrics. I'm a proud fellow, and they came out in 2019 with a policy statement on how racism affects childcare, and they had a number of different recommendations in 3 different larger categories. I'm not going to have time to go through all of them, but I recommend the link below is the reference if you're curious what the organization recommended as a whole. Their recommendations fell into 3 different categories: optimizing clinical practice, so what I can do as a provider to make my practice a safe space, welcoming all persons. Another category is optimizing workforce development and professional education, so making sure that all medical students and residents are trained to be sensitive to these issues and kind of recognize our own implicit biases so that we can make sure that we provide equitable care to all of our patients. And then the last category is optimizing systems through community engagement, advocacy, and public policy. So these were my 4 favorite, but just engage community leaders to create safe playgrounds and healthy food markets to reduce disparities in obesity and undernutrition in neighborhoods affected by poverty. So we didn't even touch upon this, but because there's, as one of our panelists showed, we don't have a ton of data, but we do know that obesity is much higher in underrepresented minorities, and there are neighborhoods and areas that have food deserts, and so are more likely to kind of contribute to those. So kind of encouraging safe spaces and healthier nutrition in those communities, but we have to find those communities first. We also have to advocate for improvements in quality of education in segregated urban, suburban, and rural communities designed to better optimize vocational attainment and educational milestones for all students. We haven't yet even discussed about the education system, but pediatric healthcare is very tied to our school system. So if we can support our school systems in this way, it might help reduce racism as well. And then the last 2 are to advocate for increased access to support for mental health services in schools designed to help teachers better manage students with disruptive classroom behaviors and to reduce racial disparities in school expulsion. So this was recommended before the pandemic. I would say the pandemic exacerbated this issue. I'm sure you've all heard the studies and seen the reports that depression and anxiety has dramatically increased in everybody, but especially in women, and in particular in the LGBTQ plus communities, pardon me. But it's so important that we have a mental health care system in this country. I think Dr. Derksen mentioned that he wasn't able, or he mentioned it briefly, but it's a huge proponent of providing primary care to pediatric patients as well. And finally, to advocate for policies and programs that diversify the teacher workforce to mitigate the effects of the current demographic mismatch of teachers and students that affect academic attitudes and attainment for all students. And this furthermore is reinforced within their workforce recommendations. So in addition to trying to support a diverse group of teachers, I think we need to also support a diverse group of physicians. And with that, I just appreciate the opportunity to talk to y'all, and thank you so much for addressing this issue. It's so important, and I was so honored to be included today.
Thank you to you, Dr. Felman, and to all of our panelists for presenting today. We will now open the discussion to the committee members present here to ask questions of our panelists. Each committee member will be initially limited to 1 question. However, if time allows, additional questions will be permitted. A reminder that Q&A is reserved for the committee members only. The committee may ask questions of the entire panel or individual members. Committee members must be recognized by the chair, by myself, before asking any questions. Due to the large number of members in our committee and the short amount of time, each committee member will be limited to 1 question, and then I will ask for follow-ups as time allows. I will go through our committee members individually. Angela Banks, do you have any questions at this time?
Yes, I did. Thank you so much to our panelists. I really appreciated the informative presentations that you provided. And Dr. Derksen, you had mentioned, the crux of your presentation dealt with the shortage and the number of residency slots. And I know you mentioned part of the challenges funding in terms of how those slots get funded, but I'm wondering if you have any ideas about federal, state, or local policy or other types of interventions that would help increase the number of residency slots for family practice here in Arizona. Thank you.
Yeah, I'd I'd be a little broader than my own specialty in family medicine to include general pediatrics and general internal medicine and the med peds as well. And I think we've made some progress. We are probably our quickest leverage is that this is a really bipartisan issue. This got really good bipartisan support, and we did get a $5 million one-time appropriation that it's non-lapsing, so it can be used until it's gone. We don't have to turn it back if it's not done by a certain time. But the idea is to create more residency programs in areas of need, because it's not just a numbers issue, because the huge majority of our residents get trained in Phoenix and Tucson. I mean, it's just where the action is because of our accreditation of having to do it in a hospital and do a certain number of rotations. But the idea is also to distribute and balance that wonderful training that happens in those programs in rural areas. And so we made some progress on that. We need to make more. What I'm hopeful is if we can have some early wins in standing these new programs, that it'll be a recurring appropriation, because the startup for those can be quite expensive. You don't really get reimbursed by Medicare and Medicaid, Veterans Administration, HRSA for residency programs until they're already there. And there's 2 or 3 years in the steps that you have to do to get accreditation and get the things done. The quicker way is through an academic community partnership. But there's still a number of steps you have to go through. So our state has taken some good steps. At the federal level, we need some relaxation of who can be a sponsoring institution. We need help from CMS to recognize federally qualified health centers, rural and critical access hospitals, and others as places that can be sponsoring institutions. And that process needs to be quicker, because this isn't an issue, at least in Arizona, that we can sit on much longer, because we're already so far behind. We need to be doing these things the next 2 years, really, to not have a real crisis on our hands down the road.
Thank you. Rebecca Browder.
Hi, this question is for Dr. Feldman. Again, thank you all of you for being here today and providing such valuable insight to our topic. Dr. Felman, you had some, on pages 53 and 54, you had some ideas about how to go about correcting some of the issues. I'm just wondering what you would suggest we tell our local leaders, our legislature, on how to go about making some of the changes that you recommended. Or if you've seen another city or state do it really well as an example or a model, who we could look to.
Well, I mean, I randomly looked at California because it was close to us, but I feel like looking at them, I mean, they're definitely much higher ranked in terms of access to care. Those would be a matter of, I believe, approving a change within the state budget for Medicaid. Medicaid, as far as I know, is budgeted through the state. So with that budget process that I believe is just finished for this year, but perhaps starting to lobby for increased access. So increasing that medium income level for Medicaid patients, getting rid of the waiting period, and having continuous coverage. So during the pandemic, everybody was allowed to not reapply for Medicaid if they had a change in income. But now that the public health emergency has ended, this has become a big issue for a lot of my patients, where they find out all of a sudden that their Medicaid has been canceled because they just didn't reapply. So if we can kind of advocate for those 3 things, I think it would dramatically improve access to this amazing healthcare system that we already have in place. And as I showed in that one slide, that many people are already kind of enrolled, but if we just make it easier to enroll for those patients that those patients and families that qualify, that would help hopefully reduce the disparities a little.
Thank you.
Tessa Dysart.
Yes, thank you all to the panelists. This was a great presentation and so interesting and disturbing in many ways. And so my question for Dr. Felman and perhaps Dr. Derksen as well, if you want to comment on it, the distance that people have to travel, especially for subspecialties, was fascinating to me. What are ways, what are maybe other states doing with large rural communities where we could perhaps take medicine to people rather than having them travel to subspecialty providers? Are there unique things that you see other states doing that we could encourage our state to adopt?
Do you want me to answer first, Dr. Derksen? Is that okay? Okay, I'll give one suggestion that I didn't mention in my presentation, but I think that even though the pandemic was an awful experience, one benefit of the pandemic is that we got much better as a healthcare system utilizing telehealth. And there are some, and the government kind of very quickly moved to make it easier to use telehealth and get billed equitably to undergo telehealth. And even though telehealth isn't the end all be all, there are a lot of things that you can do over a video visit that make healthcare much more accessible for rural patients and families. But one easy thing would be perhaps to continue those exemptions, which some of them have gone away since the public health emergency has ended, to have equal funding for those visits, so I think many states have, but also to reduce some of the restrictions. I think the DEA is looking at, like, for example, during the pandemic, we were allowed to prescribe controlled substances for our patients via telehealth, which for pediatrics means ADHD medications, which have a low risk for abuse, but are kind of unfortunately in that same category as controlled substances. So when we had the opportunity to kind of do telehealth or conduct telehealth visits for our patients with ADHD, it reduced the need for that patient and family to have to go into the office. Now, they had to have internet access. That would be another thing. Maybe if we improve the telehealth, improved access to telehealth, also improving our networks in those rural communities, because if you don't have internet, you can't also conduct a telehealth visit. So that's one idea. I don't know, Dr. Derksen, you probably have others.
Yeah, the telehealth's key. Arizona was a leader in covering telehealth services through their Medicaid program, and that was really important. We can now invest, there's millions of dollars coming in from the federal government to expand broadband. So last week, as part of our Real Health Conference up in North Country, we visited the Hopi Nation and the hospital there in Palaca, and there's no broadband. So a lot of these places could really benefit by expanding our broadband into those areas. And we really need to do that for telehealth, because you can't have things, going on and off when you're trying to give advice over the phone. So we have the opportunity to leverage those federal dollars that'll be coming in to do that. The other part is, it's really alarming to me, and I'm guessing also to others, including Dr. Felman, that we experienced a big drop in Medicaid enrollment last month, a big drop. And we've been kind of worried about this for some time. Of that 2.5 million individuals enrolled in Access, we're expecting 500,000 or 600,000 may lose their Medicaid coverage, not because they're no longer eligible necessarily, but because of the redetermination. They have to update their information. We may not have a current address or a current phone number, but we have to redouble our efforts there to make sure that people aren't pushed off. And then when they really need the coverage, they can't get it, because that can be so devastating, especially in rural. So we have opportunities to expand our broadband, expand telehealth services. That expands our reach, but we can't do it unless we have that core issue of broadband in some of our most remote areas. So we have an opportunity. We have to take advantage of that window of opportunity. It doesn't open up very often, but we'll have millions of dollars to spend in the state. Let's make sure it happens where it really needs the most access to care.
Member Ferguson Boney unfortunately had to leave for the moment. She had a conflict. So David Kim.
Thank you, Madam Chair. I would also like to thank the panelists today for valuable information and their insight. I want to sort of let you know that as a first-generation immigrant, I, like many others, sort of grew up without medical insurance until I got to college. So I cannot afford to get sick because if I were to get sick or injured, that meant that I wasn't going to be treated. One statistic that kind of triggered me, I guess in a way positively, but also it got me thinking was Dr. Feldman's PowerPoint presentation about the disparity of the rate of uninsured children by race. While I do see the difference among different races, it seems that the maybe statistically significant difference appears to be with American Indian and Alaskan natives. So that is, I think, quite clear to me. And so I was wondering why that would be the case. And I think maybe during the Q&A, I think you've already answered some of those questions. But I guess more importantly, does that mean that we are okay with the level of accessibility by other races instead of Arizona, given how small the difference appears to be?
Can I just take a crack at one part of that? Part of the Affordable Care Act when it was passed was the permanent reauthorization of the Indian Healthcare Improvement Act. That was a critical piece of the legislation that happened. So any individual, American Indian individual, can be covered up to 300% of the federal poverty level with no copays or deductibles. And yet we have a very high percentage of our American Indian population that doesn't have health insurance. I think part of it's education, that you are eligible for Medicaid up to 138% of the federal poverty level as an individual or family. We just expanded this last session eligibility for kids care that will add another 15,000 or so kids because it expanded the eligibility up to what, help me there, Dr. Felman, it was, I think 220% of the federal poverty level. So that was good. Those are good progress.
Yeah.
But there's some education issues that people think because I have Indian Health Service, I'm a tribal member, I can go there, I don't have any copays or deductibles. I don't need to sign up for Medicaid or health insurance coverage. But if that service isn't offered, like in Palaka, there's a limited array of services that you can get. If you need a referral for a pediatric endocrinologist or for a visit for something else, and you don't have insurance, that can be devastating to a family. So when we have to take advantage of getting people who are eligible enrolled at the time of their visits, whether it's on an Indian Health Service site or a tribal operated site, but we have a similar challenge along the US-Mexico border in the 4 counties that we have there, is that people may not realize that you're eligible for public benefits, including maternity and infant care, women, infants, and children's program, those types of things. And what we ought to be doing with our eligibility and enrollment systems is there's no wrong door. If you're eligible for one public benefit and that you sign up and you do all that, you shouldn't have to apply in 3 different places to get eligible for the other things that we know from the evidence base. When you get supplemental nutrition assistance program, it makes a huge difference in health outcomes. So, so those are things we can do within our sphere of control in our state to make it easier to get the care that they need, the primary and preventive care. Those are things that we need to really continue to push for. But part of it's also education about, hey, these are the things available. This would really help you. This would really help your family. This would really help those Indian Health Service and tribal operated sites with the finances, because then they get revenues from the billing and collections from those when they do see the patients.
Thank you, Doctor.
Thank you. Teresa Rosas.
Thank you so much. And thank you, Madam Chair. Thanks to all of the speakers. So one of the questions we have before us, I'd like to pose for Ms. Hagerman. One of the questions we have is whether our state has sufficient data or systems to be able to sufficiently and accurately identify racial and ethnic disparities in pediatric health care. And you tried to teach us, I tried to learn about disaggregating data. So my question is, if we agree with you that we need to disaggregate the data. We need to do it by location and not just race and ethnicity, that we need to take the numbers we have and break them down further. How do we do that? What's our step one? How do we ask for that data? Who do we go to? Or how do we confirm that it doesn't exist before we ask someone to help us get that?
That's a great question. Thank you. The first thing you need to do is identify the program or the health outcome that you want to address. That's the number one, because I've heard people keep saying, oh, accessibility to care, but what kind of care? Because depending what kind of healthcare it is, I can tell you the variables that impact accessibility can change. So I recommended that EDDI program, but I gave the data sets that I know have that those geographic locations, because that's key, right? So I recommend, it depends what age group you want to do, but I really think, and this is the other thing, is you just can't pick one data set or one program. You're going to have to pick multiple. So if you wanted to go, okay, you know what, let's do 1, 0 to 5. What's the most comprehensive data set there? 1, 2, maybe that's how I think you need to do it, because there's not going to be one data set that answers it all. But if you want to do it, I think I honestly start with EDDI. It depends what you want to look at though, but start with that program, and that's where you can start diving into the data. So identifying what groups are behind, and then where they reside, where are these moms giving, where are they giving birth at? You know, all these factors play into it, but I think that's number one, is identify the program and data set that's most rich. That's what you have to do. And to go back to what you were saying too, sorry, but when you were saying for government programs, that's another challenge, is they do not put a lot of their data up. There's many reasons why. They're very understaffed. You know, CDC and HRSA, people don't realize this, but they require so much of these State Department health workers. You might have one person working a whole state program, and they're expected to do the evaluation, the rollout. So the problem with that is we don't really get to see the data. We have to access the data ourselves. So I think maybe, again, start picking some age groups and start picking some big data sets that you know are comprehensive. Like the EDDI one, it's going to cover every single birth in the state, and it has about 120 variables across maternal healthcare, et cetera. So I'd say that's step one.
There's other sources. One is there are data use agreements in place between our state Medicaid program and Arizona State University and University of Arizona for Medicaid data. Some states, I think these are best practices, and some states have an all payers claim database. But if we want to focus on the pediatric population, really having a better population perspective and analysis of the Medicaid claims data would get us a long way toward answering the types of questions and helping us target policy interventions to really improve some of the health outcomes and the health disparities, you know, kind of these intractable problems in certain populations in certain areas of the state. And so I think one of the things we could do is really leverage better our Medicaid data use agreement with Access, so that we can better analyze where the problems are, where the utilization really, you know, makes us think we could do better as far as preventive visits, or we're just starting a system where Medicaid's going to start paying for community health workers and community health representatives to help with management and case management. And I think that kind of data would really help us say, you know, this could be a broader team that really addresses some of these disparities that we're seeing in certain parts of the state, but also American Indian, African American, Hispanic, Latino populations, where we're seeing these huge variations in health outcomes in pediatric populations. So I would also suggest, in addition to what Amanda was just saying, is that the Medicaid database, we could, with an eye toward the population perspective, we could do a lot with that to help us.
The only problem I was going to say with Medicaid claims is they do not collect granular geographic data. So they might go as low as county is the only thing.
No, it's where the site of service is. So you can get zip code data down to, but it's where the service is provided. So you can get that from the claims data.
Okay, that's great.
I just wanted to add on to that just a little bit as a clinician and a practice, like I spend 50% of my time taking care of patients. There are limitations to claims data. That what if a
Sure.
provider doesn't bill for something, and just to understand and recognize that that's always going to be a caveat, that claims databases are not the end all be all. And it's just important, as Amanda suggested, I think, to take into consideration multiple databases because of that. Like you're going to miss out on some nuances just because it depends on me as a pediatrician remembering to code and bill for everything. And when you're seeing 20 to 30 patients a day as a pediatrician, you forget to sometimes. So.
Good point.
I have a question for the panel, and it involves the same question about data. Medicaid and Access in particular, they have the program called the Early and Periodic Screening, Diagnostic, and Treatment for childhood. And there are a lot of forms and information that's filled out. Now that's free, my understanding, for all kids 21 and under, I think. We're part of the Medicaid program. Is there any data obtained in those forms that have relate to culture or national origin or race or demographics that we could look at that data, or that an individual studying that data would be able to look at the data and compare that to all of the other information that occurs in all of those well checks?
As far as I know, there is no requirement to complete those. I mean, that's the form that we use as a system, and we have to incorporate many different variables as part of the EPSDT. It's part of my day-to-day work when I'm seeing patients, and we have to document every single one of those requirements within our notes. Otherwise, we won't get reimbursed appropriately by Medicaid or Access or the CHIP program here in the state of Arizona. That was one of the reasons why I suggested perhaps considering including another screening tool. That said, like, we as providers are inundated with various screening tools. We just implemented screening for anxiety because the United States Preventative Services Task Force recommended that all kids ages 8 and up, and including adults, be screened for anxiety every single year. And I don't know if that's a pandemic related thing, but we also are kind of on a forms or screening overload at the moment. So asking doctors to do one more thing with the same amount of time and being paid the same amount of money. So I think whenever you're considering asking or implementing another screening tool, ensuring that that screening tool is billable and we can make some money for the time we spent using that tool, like we did with developmental screening in children. So I know we do utilize developmental screens, and Amanda did speak about those. So at every 9, 18 month, 24 month, and now 30-month visit, we screen for developmental delays in all practices. The Ages and Stages questionnaire, which she reviewed, is one means of evaluating. There's another tool called the PEDS tool that also is used, but perhaps thinking about researching a racial disparities, or just spending more money looking at that. But I think that when registering and in billing information, you can gather some information about their demographics, but I'm not as familiar with the databases as probably
So
Dr. Derksen.
So the data entry fields for eligibility and enrollment, I think, is where you're headed there. That does have data entry fields for that. Now, how accurately those are filled out depends on who's helping the person sign up. But when you do your eligibility and enrollment, and that's through Department of Economic Security in our state for Access, it's not Access itself, it's through DES. But the eligibility enrollment system does have those data entry fields. So you wouldn't find that so much in the claims data, but for an individual that has a claim, there's an eligibility and enrollment. And that's why the redetermination process is important, so that you have more accurate and up-to-date data, including, where a person lives now and their income and all those types of things. But you can get that kind of data from the data entry fields, but it's only as good as the people entering the data into the eligibility enrollment system. So we have a system in place in Arizona where both at the state level, but also it's federal. Remember, Medicaid's a state federal program, you have to be certified as a navigator to help an individual and assist them with eligibility and enrollment. But often it's done, most often I would say it's done when a person comes into a clinic, whether it's a, federally qualified health center or a private practice or whatever. It's the entry person kind of going in and going through the eligibility, helping a person complete their form. But there's data on, both on the claim side, but in the eligibility enrollment, what they get at those data entry fields that you were just asking about.
Thank you very much. Professor Jonathan Rose. Oh, Jonathan, your system is on mute. I will.
Can you hear me now?
Yes.
Sorry. First of all, I want to thank the presenters for their great presentations. I hope, Leslie, we might be able to get written copies. It's a lot to digest. I didn't take notes. I'm sort of past the notes-taking age. But anyway, that would be very useful. I think we certainly got some Arizona-specific data from Dr. Felman and forgotten the names, and the other doctor from the U of A. The presentation by Amanda was much more general. A question I have, so it's clear that we need to get more data, and my question also goes to sort of the capability of our staff to get all this information. The committee is going to need help. And I don't know if the staff can develop it on their own or they will have to gather it from other sources. But also with regard to what Amanda has said, since her information was much more general and not Arizona specific as the other two were, it might be useful if she would just give us a document in writing of the kind of much more specific Arizona data that would be useful for us to get.
To answer part of the question, we will receive a transcript after the session so that we will have access to it for the committee members, and then we can follow up as well if we have any additional questions that would help us along our way as we do this report.
And just to let you guys know, those programs I mentioned are in Arizona, just to let you know. The state programs.
Thank you very much.
Mm-hmm.
Christina Sandifer.
Yes, thank you again to all three panelists. I think my question is probably best answered by Dr. Derksen, but certainly happy to have any or all of the panelists answer it. And I don't want to put the cart before the horse too much because I do agree with all of you that we need to look more into some of the data and the nuances. But to the extent that primary care physician shortage in particular is causing disparities of the type that this committee is looking into, I was wondering, we talked about a few solutions, but do you think that this could be remedied in part by any particular scope of practice reforms that the state could put into place? Potentially, I know the state legislature has done some of those over the past several years, but things like maybe allowing RNs or pharmacists or other health providers to practice to a broader extent, toward the top of their training. If so, do you have any specific recommendations as to what those scope reforms might be? And again, I think this is probably more of a question for Dr. Derksen, only because I know that Dr. Felman talked more about specialties, and I'm guessing that the scope of practice reform isn't going to help much there. But if I'm wrong, please educate me. Thank you.
Yeah, again, I always like to look at, when we do something well in Arizona, sometimes we focus so much on our blemishes and our challenges that we don't look at things that actually made a huge difference very quickly. And one of them this year that I was proud of, so I'm a family physician, but where I trained and where I was on the faculty for 25 years at University of New Mexico, we housed in our family and community medicine department a physician assistant program. It was a wonderful collaboration. And this year, the legislature considered, and we helped through our various advocacy groups, expand really the scope of practice of physician assistants. Right now in Arizona, a supervision agreement is there, and that's not a bad thing. It's kind of a decentralized way to do almost like graduate medical education for physician assistants. But they have to have a supervision agreement in perpetuity. And this one says after 8,000 hours, which is about how much time you spend in a 3-year residency program, that you just need an agreement, not a supervision. You don't have to review a certain number of charts or, have someone in the practice that's always kind of looking over your shoulder. So it put the physician assistants on a more equal footing with nurse practitioners, like family nurse practitioners that have an independent scope of practice. But we do have to balance a little bit, because we don't want folks to get an expansion scope of practice for things they're not adequately trained for. And so in addition to, in a lot of the training right now for nurse practitioners and physician assistants and others is online. And there has to be a period of time where you actually do clinical care and you're seeing patients in an apprenticeship type of thing. In medicine, we do that through residency training. I think it would be valuable for us to kind of follow the example that we just did with physician assistants and really look at, let's make sure that our folks that are licensed to practice in the state are practicing to the full extent of their scope of practice, but don't go over that and have people doing procedures that they're not trained for or they haven't been supervised for and all that. So we have examples of how to go about doing that, but I think it's critical that we use physician assistants, nurse practitioners, and others to help expand our primary care base. One that we just started this spring in Arizona, we haven't had one for many years, is a midwife program. We have 2 entire counties without labor and delivery services, La Paz and Greenlee. And if you look at some of the health outcomes there, we have some real challenges in access to care. Usually when you don't have labor and delivery services, you also pretty thin on the prenatal care and postpartum care, which is particularly important for kids after they're born. So midwives would be another one I'd add to that group. But I think we're on a good pathway to doing that. The other one that just happened, I think the session before last, was voluntary certification of certified health workers, community health workers. On the reservation communities, they're called community health representatives. Access is just working through our state Medicaid program of figuring out a way to bill for those services and for community health workers to be paid for those as part of a team. And I think that's good progress. So I think you're absolutely right. The nature of your question there is that we have to be smarter. We can use best practices and steal them from other states, as we've done in a number of instances. But I think you're absolutely on the right track. We need to do that, but I think we need to be careful about making sure that people are adequately trained, but also through our certification and our state licensing, that we're making sure that we're protecting the health of the public as well. That's a tricky balance sometimes, but I think Arizona has actually made some real progress in those areas over the last couple of years in our legislative process.
Thank you very much. Beverly Traver.
Thank you to all of the panelists and to you, Madam Chair. My question, I believe, is going to be addressed to Dr. Felman, but obviously it's open to any of the panelists if you have input on it. Dr. Felman, you mentioned briefly the potential for cultural impacts to have an effect on diagnoses. For example, I think you mentioned the Latinx community and how that could possibly be a cultural element that precludes or prevents them from answering either honestly or accurately, totally, when they go to doctors. That could be sort of a pre-screening thing. And I do believe that that's an issue. My question, though, I didn't hear anyone speak to the potential of misperceptions or mistreatment to also have a huge impact on certain minority communities. And I'm really interested in hearing about that. As an African-American woman who is currently 5 months pregnant and has had some negative experiences in the healthcare industry, I know for a fact that when you feel like you're being treated less than, or they're not meeting a certain standard of care, you pack up and you leave. You're more likely to say, forget it, it's not important, I'll get over it, it'll resolve itself, and to not seek medical treatment. I do think that's a huge, huge part of minority communities potentially not receiving adequate or necessary medical care while they are pregnant. Which could then lead to the same mindset or mentality when the child is born, that, maybe all of these checkups aren't necessary, or the doctor doesn't like me, or they're very short with me, or they interrupt me, or they don't listen to me, or they treat me like I'm less than. So I'm not gonna subject myself or my child to that experience. Can you talk a little bit about, does the data even exist to show how many minorities are capable, they've got the transportation, they're in, within close radius of getting medical care, but they choose not to for other reasons, like they're not being listened to. I think there have been multiple studies done on African-American women and how their pain, when they say they're in pain, they're not adequately receiving medication or care, or the doctors aren't listening to them, and so they just stop talking. And that could, obviously lead to death and other things. So is there any data, first of all, to speak to that issue of possible mistreatment, misperceptions, or a lack of education in the minority populations that is then leading to sort of an underutilization of medical services, despite these issues of distance or not being available, or transportation or anything like that?
Yeah, no, that's an excellent question. And one of my best friends is African-American and just underwent a whole battle with cancer, and hearing her perspective, and just at times she did not felt heard, and she did not felt like people were listening. And there, I believe there are data. I don't know all of the studies within the 2019 AAP policy statement on racism. They go through some of the smaller studies, and I feel like now all of the major pediatric organizations have put a highlight on eliminating racism and trying to do our best to work within the systems that we have and the systemic racism that exists, and acknowledging that we all have implicit biases and that people are going to feel a certain way. So I don't know all of the data, because that's not my area of expertise. I know anecdotally, I've seen that. I care for, or I've cared for, when I was at my federally qualified healthcare center job, I cared for a predominantly Central American patient population. So Latinx, most of them were immigrants from Honduras, Guatemala, and El Salvador. Here in Arizona, I see a few members of them, but they also have different perceptions, as I explained with the Hispanic. Like, they are very deferential to the physician, to the point where they're not going to bring up an issue unless the physician sees it as an issue, even if they have concerns. So I think that there are definitely areas of opportunity for studying this issue, and there are smaller studies that have been done. I just don't know all of the data. I recently attended the Pediatric Academic Society's meeting in Washington, D.C., where one of the panels was on DEI research, and one of the papers that they focused upon at this plenary session, which was in front of several hundred pediatricians, was on perceptions of patients in the NICU, and doing focus groups of parents in the NICU based on their race or ethnicity. And some of the quotes from the patients and families from underrepresented minorities, I mean, I'm getting goosebumps, and my heart broke when I heard what some of the providers told them and how they perceive that within the focus groups. So I think that this is an area that we as pediatricians are trying to focus on and do our best to mitigate those biases by improving our professional education, by trying to encourage underrepresented minorities to join the healthcare workforce so that we have more physicians of color and underrepresented minorities within our workforce. And then along those lines of the last few slides, like focusing on education as well, because I wonder if that's part of the problem within our school system too. But it's all linked, and it's incredibly systemic. And I think we're just getting at the tip of the iceberg. And I don't know if Amanda or Dr. Derksen are aware of other larger data sets or studies, but that's just what I know as a practicing pediatrician. Yeah.
I'd say nursing workforce does the best as far as reflecting the diversity of the population they serve. They've been a leader in that for many years. Dental does the worst. Dental is almost all private schools now. And so the fiscal obstacles of getting into dental school and accruing that level of debt if you don't have independent resources or your family can afford to send you there is a real issue for dental. Arizona actually does better than other states as far as a diverse health workforce on the physician population, pharmacists, nursing, but we could do better as far as having our matriculating students reflect the diversity of our state. Part of that is that we have a ways to go on our faculty and the folks training to reflect the diversity. When I was in Palaca last week on the Hopi reservation, it was really gratifying. One of the students I taught at University of New Mexico, a Hopi physician, was there giving a lecture to us about what it was like to go back home and provide services, and what that meant as far as opening the doors and the things that folks would say to him that they wouldn't think of saying to an Indian Health Service doctor that's there and gone within a year or two. He's been there, since he graduated. And he now has gray hair, which makes me feel really old because, when your students start having gray hair, maybe it's been a few years, but it was really gratifying to see that. And I think those are individual success stories, but we could do better than we're doing right now. Part of it's removing that fiscal barrier to pursuing health professions. But equally important is getting students to think about health professions careers even as early as grade school and high school. And we do have clubs and other things where people can pursue that. But there's no more powerful voice than someone from their community being a role model and example. For me, it was my brother. He went through medical school, and I thought, well, I could do that. But for a lot of folks, when they see folks that are practicing in their communities and out there, it really is a motivator. You say, I could see myself in that role. We could do much better in the state. We've done pretty well compared to other states, but in my view, that's not good enough. We could do better than we're doing right now.
Beverly, I was going to add in something too, as you asked specifically on data. I do not think at a state level that there's any qualitative data that goes into the perceptions of African-American moms. It might be very limited. And if there is, it could just be, we may not have actual granular geographic region on it. So I do have some recommendations if you are curious on, okay, how would I find, if I did want to find out about some perceptions? One, your state department or county department of public health, depending where you want to look at, their bureaus may be conducting qualitative interviews. But remember I mentioned before, when you find out the who and the where, you got to find out the why and how. So I think maybe another idea too is find out which, if you're looking at African-American moms, what cities are they having some of the poorest health outcomes when it comes to maternal and child? And then from there, look at where are they going for care, let that hospital level. I'd be curious. And then from there, qualitative interviews could be conducted. I wouldn't be surprised if the state is already doing something along those lines. So maybe reach out. I recommend that.
Thank you. Professor Whiteman Runson. Okay. Henry Whitmer.
Thank you. Dr. Derksen and Felman, this question would be directed towards you. Dr. Felman, in your bullet points on what to do, you had a section on loan forgiveness in there, and that's something I want to follow up with and flesh out a little bit. So you graduate from medical school, you're saddled with hundreds of thousands of dollars of debt. And it seems to me we're talking about two types of solutions here. One that would foster the actual practice of medicine in these rural areas. And then we also need to talk about things that would drive people to those practices, right? So like when I graduated from law school, I didn't care if they had the fanciest building, the best internet in Chinwe. That was not going to be my motivation to go practice there. What do you actually think your residents and your students, what can we do on a federal level, like public student loan forgiveness, to incentivize and actually drive them to these places? Because I don't see just having good internet or paved roads is moving the needle as much as having people there that can actually do this. So do you have any thoughts, suggestions?
I mean, I think Dr. Derksen, this is your kind of area, but I mean, personally, I benefited from the National Health Service Corps program and ended up kind of thriving at a federally qualified healthcare center. And it kind of gave me the career trajectory that I have. And I'm so fortunate for that program. So it's making it easy for doctors and especially to encourage people to go into primary care, because when you're saddled with all this debt, a lot of the, salaries for primary care physicians are not the best depending upon where you're going in the country. But with these loan forgiveness programs, that can open the door. But I think Dr. Derksen made the suggestion of making it possible to have other residency programs and other I think that if we open the doors a little bit more to different areas that have underserved patient populations in combination with loan forgiveness, I think that that's kind of going to be the key, but he knows more about this than I do.
I mean, would that be as simple as tying into a metric, like if they had an HPSA of 20 or above, then that would activate some kind of program we can propose?
So, yeah, one of my favorite subjects, but I look at it as a toolbox. There's a number of tools you can use, and it kind of depends on the community and the population that you're trying to target. One of them, the health profession shortage area scoring criteria that I showed you, the up to 25, it's used for 40 federal programs. Funding criteria. It might help fund a community health center or make a decision about, okay, you're higher on the list to get your hospital replaced in a rural area. The one probably we're most familiar with is the loan repayment program. There's also a scholarship program. For every scholarship that they do, that's the best one. I wish I had had that in medical school. I wouldn't have to accrue so much debt. But you got paid a certain amount in addition to paying for your tuition and fees to be successful. There's Indian Health Service loan repayment. There's VA. There's military. So there's a number of tools. When I was president of the Medical Society in New Mexico, we did the most popular thing we did for health providers in New Mexico was and I'm hopeful that we can do this in Arizona, is creating a tax credit. If you practice in a health professional shortage area, you got a state tax credit. And it varied depending on what licensed health professional you were. Really a great retention tool, keeping people in those areas where they really needed. I think we weren't clever enough in New Mexico to do this, but Colorado just did this. And they also gave part of the criteria, in addition to practicing one of those areas, was to give you, one of the requirements is to be a preceptor. So we really need community-based preceptors, because we know when we do training in areas of need, people are more likely to go into practice there. And so we need field faculty, we need preceptors out and about. And I think, some of these places are the best interprofessional places to learn how to really practice in a rural area. So I think a preceptor tax credit would be a wonderful tool to add to the toolbox that we have in Arizona. So those are some of the things. But the other part, I think, is also the community has to come together and put together a package of how to keep, first of all, recruit people to the community, how to keep them there. And I think one of the ways to get upstream on that is is really to create these community-based training programs, whether that's a nurse practitioner, physician assistant, midwife, others. Then you're building a self-sustaining system, and then you can add on these other tools of loan repayment or enhancement types of things so that you can compete with the places where most of our folks train in Phoenix and Tucson, that you're creating a set of incentives and balances that helps keep people there. But it's not just one approach, because every community is a little different. So there are programs at the federal level. There's state loan repayment programs at the state level. We have one. We have a recurring appropriation at the colleges of medicine in Tucson and Phoenix with the University of Arizona. If you agree to come back after your residency training in primary care, you get your tuition and fees paid for. It's kind of a 1-for-1 year. So if you got it all 4 years of medical school, you'd owe back 4 years in one of our health profession shortage areas. So that just started. We're just getting our first graduates to come back to the state, so they finish medical school, they've got their tuition and fees paid for. They do their residency 3 or 4 year kind of process. Then they come back and work in these areas, and that helps them, to pay back their obligation. They still get paid by the community health center or the Indian Health Service site or wherever, but that's another tool. There's a number of other kind of clever things that states have done, and I think we could draw on what other states have done to help us with our unique circumstances in some of our areas around Arizona. But those are a couple.
Thank you. We have one last member for our first round of questioning, and if for our panelists, if you're able to stay around after the first round, please do so. Our meeting will continue on until around 3:30. But I do, after this question and answer, I want to give everyone an opportunity for a brief 5-minute break. Eric Yordy.
Thanks, Leslie. One of the blessings and curses of being last alphabetically is a lot of my questions have been answered, but I also stand between you and the break. So my question is actually a little bit of a targeted question. Dr. Derksen, you mentioned that Medicare has capped the number of residency slots that are fully paid by the federal government. And one of our jobs, duties, opportunities on this group is to make recommendations to the federal government. And so I wanted to talk about that just briefly. And I know with Medicaid, we can do, we put in $1 and they put in $3 and we can have the state help fund. But for Medicare, my understanding was those are fully paid residencies, but there's this cap, and our population growth has exploded. And so we have a lower number than we might have. Could one of our recommendations be, and they may do this already, to do something like make a recommendation that the federal government look at that cap and not only increase it, but also do some sort of regular reallocation so that Arizona would get a better percentage or proportion, almost like they do with the House of Representatives every time they do a census and reallocate House seats. Would that be a recommendation that we from Arizona could make that would be helpful in the state?
Yeah, I like the way you're thinking. Medicare is the big funder by far, although in our state, Medicaid comes pretty close. Remember, Medicare usually over age 65. There's a Medicare, Medicaid, the dual eligibles, what we call the Arizona long-term care system that covers, a subset of folks in our state that might be a child with a disability or older. So Medicare helps us with some of it. The pediatric residency part and the children's hospital kind of residency, there's some unique things that get a little wonky about how you might change the federal policy that would help us, but it's a little bit of a thing. But on the Medicare, certainly, there's no cap if you start a residency program in a place where it's a health profession shortage area that hasn't had one. Mm-hmm. You have to be careful about doing that because they'll cap you after a certain number of years. So you don't want to start out too small. For example, at North Country, which is a federally qualified community health center system that has a whole bunch of federally qualified health centers across the northern tier of counties in Arizona. North Country started a couple of years ago 4 residents per year. So they're just graduating June 24th. Their first cohort of family medicine residents from that program. They actually asked me to come and talk at it. We've been supporting them through our HIT program for a while. But it's gratifying to see. But they could get capped. So what we need to do is use some of that funding we just got to help them expand their existing to 666 per year, which they can handle in their community. So you don't want to start out too slow because you'll get capped at a lower number, and we have a number of sites that have done that. But we do have an opportunity to expand residency slots and get Medicare GME subsidies. I call them subsidies because they don't, depending on who you talk to, it doesn't cover the full cost of a residency program. You need the combination of Medicare and Medicaid GME really so that you break even or you have a slight positive margin between the direct and indirect money that comes in through those programs. But it's the funding formulas for Medicare graduate medical education are ancient. They're opaque, and they really prioritize doing all your education in tertiary care specialty hospitals that tend to do procedures and not train primary care or care, particularly about primary care residencies. And we're seen as loss leaders and feeder systems and things like that. So the Medicare funding formula is problematic because it's ancient. And the Medicare Payment Advisory Committee has made a number of recommendations how we could really upgrade that. But the good news is that there's a real move at the federal level, especially under this administration, to try to open up more residency slots in the areas of need and in the specialties that are most needed. So there's progress on the federal front. We still have this window of opportunity with our state Medicaid program. And I'll tell you, I think we're lucky in our state. We've had really good leadership in our state Medicaid program around graduate medical education, but also around access to care. Remember, it was Governor Brewer, the one that was wagging her finger at President Obama about this and that and the other thing, but she did expand Medicaid, which has been the single most important thing we did to stabilize the finances of places that take care of kids in our state. So, and we had a little more progress this year to expand kids care. We'd like to see more. We'd like to see a dental benefit, those types of things expanded. So we can do more around that. But what a great investment. There's nothing that gets a return on investment more in our state than expanding what we're doing in Medicaid, and use it as an example. But Medicare would be wonderful to open up a few more. We have opportunities to do that in the areas of need. So.
Well, before we take our brief break, oh, I'm sorry. Did I interrupt a panelist who was planning to speak?
No, I just said thank you.
Okay, thanks, Eric. Well, before we take a break, I really want to thank our panelists for participating today. Your perspectives and information and opinions are very important, and they will continue to be important as our committee works to draft its report and recommendations. You are welcome to stay on after the break. I don't know what your timeline's like, but I would imagine that our committee that we have more questions for you. So if you can stay around, please do so. We will also have a meeting on July 7th to debrief the testimony we've received today. But in the, in consideration of how long everyone's been on this meeting, I want to take a brief 5-minute break. Welcome back to our panelists and our members. Our 5-minute break is over. It does not look like we have any public in attendance during this meeting today. And so I'd like to use that time to continue with the Q&A. But we are also going to, given the time frame that we have left for our meeting, we're going to table committee business until our next committee meeting on July 7th. And that way the committee members can add any remaining nominations to monday.com, and we can discuss the next set of panelists that can be approved in the July 7th meeting. I also wanted to thank Dr. Felman for adding the NICU data from the NIH. That abstract that we, HHS, for the abstract that that we can look at specifically in regard to NICU disparities and issues with treatment there. I did have a question just to start us off on our second round, and it has to do with the challenge I am wondering about. So we have several federal laws which require equal access to care for individuals and non-discrimination in places of public accommodation, like hospitals and doctor's appointments. We have non-discrimination provisions, through every entity that's federally funded. And in addition, we have things like the Joint Commission that talked about cultural competence and patient and family-centered care, and gave a whole roadmap back in like 2010, talked about more inclusive ways for hospitals and other medical entities to interact with communities, advocating for a more diversity in the medical healthcare, in the medical arena and the medical profession. And so I wonder where are we failing? And this is kind of a big question, but where are we failing as a community when we have all of these protections in place? We have something like this Joint Commission in 2010, and we still know that, as we heard with one of our own members talking about her experience, and as we know through that NICU abstract, that there are still these disparities. What can we do? Where are we failing?
Madam Chair, is your question to the everyone on the call, or is it just to the panelists?
It was to the panelists in particular.
I think this is a Dr. Felman question.
Well, I think Dr. Derksen earlier mentioned, especially with respect to Native American communities, the need for education. At least from my sort of immigration experience, especially where I come from, if you don't have money, you don't have benefits. Now, that was my old country, but I think looking back, that probably wasn't the case in the US or the community that I lived in. It's just lack of awareness with respect to the benefits that are available. And also, even if you become aware of it, I think there's some social stigma attached to it. And also the bureaucracy that you have to go through in order to obtain that, I think may have been overwhelming for my parents. With that, I'll turn it over to the panelists. Thank you.
I think there's another factor that you made me think of as you were speaking about this, is that there is a fear that if you access a public benefit, that somehow you'll be reported to immigration and be deported out of the state. I think that's a real fear. We've certainly seen more of that, not only anxiety, but evidence that folks have of, whether they're in a workplace and hesitant to take advantage of vaccinations that their children need or that they should have, as adults or workers that come back and forth. And plant and pick the fields in Yuma and around Somerton and places like that. So I think those are real. As we've been going through this redetermination process, these are much on my mind because one of our busiest navigators, so she's certified by the state, federal, to help people understand if they're eligible for a program and also help them enroll, because this can be a little difficult. Some of these things aren't the easiest things to navigate. And her name is Maria Lasoya, and she's lives in the southern part of the state. And she's one of our most popular navigators because she can not only help through the systems, but in the language and in terms that folks along the U.S.-Mexico border can understand. And she's been enormously successful helping people identify, hey, you need to update this information so you can keep your eligibility, so you continue to bring your kid in and get covered for these services. So I think part of it's that real navigation of these folks doing it. I'm optimistic and hopeful that our community health workers and our community health representatives that are going through a voluntary certification process, they have to go through that certification for the state to reimburse them for those types of services, will also be helpful. We're very early in that process. I'm not sure that anyone has billed and collected for those services yet, but it's on the, we have codes for them now, so you can actually enter it into a billing sheet and be reimbursed. So I'm hopeful those types of strategies will help us with what you're talking about, because those obstacles are real and those fears aren't unfounded. So I don't know. Dr. Felman, did you have any other perspective on that?
I mean, it's such a difficult question and yet such an important one. I think it just goes back to that we all have implicit biases, and as much as there is a law in place to help prevent those biases from being realized, that it's just, unfortunately, it's part of our culture and it's hard to change a culture. But now that many organizations and and committees like yourselves are doing this work to help kind of promote this, or just recognize that this is an issue and that this is still continues to be a problem, and what can we do and what programs have succeeded and what haven't. But it has to be multi-layered. I think back to, once again, the AAP's policy on eliminating racism in medicine, and they have 20 plus recommendations, spanning all the different things that can be done in healthcare. And it's, as micro as looking at that interaction, patient to doctor interaction, and making sure that doctor is trained. I also serve on the College of Medicine's Diversity, Equity, and Inclusion Committee. And part of the work that we're doing on that committee is making sure that we're kind of looking at it at different levels too, but making sure that all the doctors, or all of our faculty within the Department of Pediatrics, one of our incentive bonus, like door openers, is that everybody completes 6 hours of DEI training every year. And so just making sure that we're aware that this is still an issue and what we can do. But that's like, so that's one level, but then taking it a step further, and what can we do in our engagement with schools, and making sure that, just like Dr. Derksen suggested, that we're getting these kids interested in healthcare, not, when they're in college, because it's too late, getting them when they're in elementary school or high school, just ensuring that they have optimal academic attainment and recognize that they can do these jobs, so that we can have a diverse workforce, not just in healthcare, but in other, in education, just so that the people who are serving, us in healthcare, but also in education, those children see others that look like them, so that they realize that they can do it too. So I think it has to be a multifaceted endeavor. And we just need to keep bringing it up and speaking about it, I think, but then funding, programs that are working, like all of these programs to help serve underserved communities, underrepresented minorities, I think can be helpful, but making sure that we reward those that are actually, succeeding at their missions as well. And that goes back to the data too. So that's this one in particular, even though we've had these, in the Joint Commission, it's hard to measure in some ways and not in others, because it's a perception sometimes and not necessarily like, are you this or are you that? It's sometimes how you feel. And just like Ms. Traver was saying, where she doesn't feel heard, how do you measure that? It's hard. They're working on tools, but maybe perhaps researching some specific data collection on that particular measure might, because if you can't measure it, you can't improve it. And so, just my thoughts.
Do any other committee members have questions? Just raise your hand.
I did want to add something on that too. We're never going to fix equity if we don't decrease the cost of education in medical school. We know that the percentage that's obtaining a bachelor's degree is going down. Why? Because it's so expensive. Same thing with med school. We put in all these roadblocks for people to get education. Why? We have probably so many people that want to become doctors. How many actually pass that exam, do well, and actually get in? Probably a small percentage. Why do we create that? We have a huge shortage. And same thing for education, but I really think the problem is upstream. We've created so many barriers and we're breeding poverty, very extremely.
Yeah, there was 1,000 applicants for 50 physician assistant positions, student positions with the NAU program that operates out of Phoenix. So we decided, looking at the data and looking how we need to expand primary care, to start a physician assistant program in Southern Arizona. And I think, part of it's that responsibility that you have to make education opportunity available, not only available, but affordable. And that fiscal obstacle is significant. It's a big barrier. It's also it's also fearful. How am I going to pay all this back? This came home recently. We have a number of U.S. medical school graduates who didn't match in the match for residency program. And so you've just accrued $200,000 on average in debt. And suddenly you can't get the residency training you need to get board certified and then go into practice. And that's scary, really scary. Dental, they're the highest. They come out the highest in debt, mostly because they're all through private schools. But $300,000 in debt on average for a dental student graduate. We don't have a public dental school in Arizona. And if you look at the oral health needs, take everything I said about primary care and multiply it by 2, and you have a pretty good sense of what our health workforce shortages are in oral health. Behavioral health, probably along that, somewhere between those two. So, we know when we invest in education, that return on investment pays off for us. As far as creating new jobs and good jobs, and also the whole array of things that happen with nursing homes and pharmacies and other things when you really have the workforce you need in a community. So I think that the selling thing across both, or whatever politics you have, is that it's not just about addressing these disparities. It's also about economic opportunity and removing the barriers that get in the way of folks pursuing their ambition and their dreams to really pursue a profession that they love and feel passionate about. So I think those are some of the things that I think we can actually do in our state. We have been making progress on them, so it makes me optimistic, but those are things that are within our reach.
David?
Yeah, thank you, Madam Chair. I think this is maybe slightly sort of a different question than the ones we have been sort of dealing with. But one of the questions that we had as the commission was not just looking at the access to the pediatric care, but also the quality. I guess it's primarily to doctors Derksen and also Felman. But do we have any concerns about the differentiated quality of the pediatric care once people have access to such care?
I don't know if you were asking a particular person. I couldn't hear that, but I did want to say how you can evaluate that is first you have to generally, if you assess any health program data and you see that a group is behind, generally they're not getting quality care, right? So then, because a lot of times it's hard to assess quality received because that's more qualitative work. So what I would do is identify those groups that are behind, like I said, do the who and where, and then from there you'll be able to assess quality. But generally that's the best way to do it, because then if you, for example, identify a birthing hospital, we were talking about that NICU example, you identify a birthing hospital, let's say that has this huge proportion of NICU kiddos, okay? And we see all these social determinants are very magnified. What you do is you can go into that hospital, you can set up interviews and talk with, okay, the leader of that NICU unit, or, I'll ask questions sometimes, what's your process of handling follow-up diagnostic assessment with a NICU kiddo? And you wouldn't believe what you hear sometimes. Some hospitals, maybe they schedule right after the kid is born a diagnostic appointment. Sometimes they don't, they let them go home. And how often are people gonna call and reschedule? So long story short, just identify where those health outcomes are behind, those hospitals or those where they're receiving medical care. And from there, start doing that qualitative legwork and you'll start figuring it out.
Thank you, Ms. Hagerman.
You're welcome.
Yeah, and along those lines, I think, with the Medicaid program and access and here in Arizona, that with the EPSDT measures, as we spoke about earlier, that is what ensures quality of care to those patients that have access. And so that is one kind of means to ensure that those patients who are the patients who are underrepresented minorities, those patients disproportionately utilize the Medicaid system. But that's why those quality metrics are in place. I'm not sure how often they're reinforced, so that could be another measure in addition to what Amanda was suggesting, like doing some qualitative research, but also just making sure that the Arizona Medicaid program is funded enough or have partnerships with groups like Dr. Derksen's that can look at the data and make sure that it's being, that care is being equitably delivered. But there are those systems at least the data sets in place, because we as pediatricians who provide Medicaid care to our patients are required to document in all of our notes that we did a hearing screen at certain ages, that we did a vision screen at certain ages, that we're checking a CBC for anemia and a lead level at ages 1 and 2. And so it's just making sure that those providers who are delivering care are able to document and deliver that care in an equitable way. And sometimes it's as simple as, for us at the FQHC that I worked at back in DC, but we've discovered that patients who got care on days where we didn't have lab in place at the clinic didn't get their leads done. And when we had laboratory services available on site every single day of the week, that dramatically increased the CBC lead results. I mean, these are very simple things that can be done to ensure, but, currently at the office where I see patients most often, the lab for most of our patients is not on site. So, figuring out workarounds where it can be either just ways to identify those barriers to care and barriers to meeting those quality metrics, because I think that the EPSDT program has a robust requirement list, but it's just, I don't know how the data is in terms of reporting at the state or even county or zip code. And Dr. Derksen, you may know more about what is reported to the state in terms of EPSDT for kids.
Yeah, we have an acronym for everything. So EPSTAT was the one way we pronounce it, but there's also performance improvement measures, PIMS, there's JCHO, the Joint Commission on Accreditation. So you go in and you audit a certain number of charts and you look at them and you see, are these things there? And they're, in general, they're good measures, they're important measures. And when, whether it's a clinic or a hospital or a system, they pay attention to those things, because if you're not accredited, it's hard to get paid. We saw what happens when you don't keep an eye on quality and make yourself vulnerable to fraud in behavioral health. There's a lot of headlines on it. From what I'm reading and understanding, there is a legitimate concern about what was going on, how people were being taken advantage of and fraudulently billing, and there will be consequences to those individuals that perpetrated that fraud. But I think as far as quality goes, when I look around at the systems of care, we have a set of checks and balances that's pretty far advanced. What those performance improvement measures and the EPSTAT and other things don't measure is, for example, what if you have Medicaid and you can't find a dentist that will accept what Medicaid pays for you for those services? What if you have Medicaid and you can't get into a site to get seen, and because they don't accept Medicaid? Because Medicaid, on average in this country, pays about 65% of what Medicare pays. And I use Medicare as the index for saying you break even. You don't make, there's no margin in Medicare, but you're often cross-subsidizing the Medicaid patients you see by the private insurers that you have. And so you do have to look at, even when you have coverage, if it's a public kind of coverage, do you have access to a provider system, a hospital, a clinic, a provider that will accept what Medicaid or Medicare will pay you? So there's also that other part of, you have to make sure that your system is adequately reimbursing to cover the costs of doing that care. Many of our rural safety net providers have gone to a system of a federal designation, whether it's a federally qualified health center or a critical access hospital or a rural health clinic, because you do it more on a cost report. What does it cost you really to deliver that care? And you get a slightly better reimbursement rate from those public payers because you serve a disproportionate share of Medicaid, Medicare, and uninsured individuals. So there's ways at that, but often the metrics that we might use to assess quality kind of don't get thrown out the door if no one will accept the payment source that you have. So it's a bit more complicated than the metrics used. I actually think we have a fine set of metrics. But if you look at the triple aim, the one we don't pay as much attention to is that last one, improving the experience of care. We heard a couple of examples of folks who had a kind of a negative experience going in, and if you've ever had to sit and wait in an emergency department, you know what I'm talking about. Is it that should be part of our metrics too? That's quality care. What's the satisfaction with that care? Did they listen to what I had to say? Did they address the things that I brought forward, or was it kind of the 5-minute visit and I can do a procedure and send you on your way, and that's the end of it? So I think the quality also has to improve as far as what we measure, because patient and family satisfaction with their care, we're paying more than twice what other developed countries paying. We should get pretty darn good care, and we should be pretty happy with it. And I don't think that's the situation today.
Thank you. I know we have talked quite a bit about publicly funded programs like Medicaid and Medicare. And in part, it's because once you have public funding, you have data that gets compiled through that source. But obviously, we're missing a whole portion of the population when we talk about simply just Medicaid qualified recipients. So for individuals who have private insurers who receive their insurance through their employer or whatever, what data sets are available that would allow us to gather information about race and ethnic minorities with regard to their interactions in healthcare, the interactions in healthcare in those capacities?
There's just a handful of states that have done an all-payer claims database. that could get at that. So you go through eligibility enrollment, and that data is collected as it is for public payers. Remember, in Arizona, like a lot of other states, almost all of our Medicaid is rechanneled through private health insurance vendors. So really, to me, and half of Medicare, is done through Medicare Advantage and other plans that are managed, the system. So, if you have United Healthcare, it might be Medicaid, or it might be Medicare, or it might be private insurance that your business pays for you to pay into. So, it's difficult. Even those states that have an all-payer claims database, boy, it gets complicated fast to really try to get at that data. So there's kind of a gap. We could get, half of our population pretty well between, what we could get from Medicare and Medicaid, and then some of the other more publicly funded ones. But it's kind of a black box when it comes to private health insurance.
That one data set that I keep mentioning, and sorry I keep saying it, but it's just so extensive, is that Eddie one. And they do collect all different types of insurance, private, all your different public ones. And you can look at health outcomes, accessibility, etc. And that's nice. And again, when you look at every single woman that gives birth in the state, and you have data on her, the child, and all these health things and where they're going, and the type of insurance, it's just so rich.
Thank you.
You're welcome.
Do any other committee members have any questions? Okay, I'm not going to force it. We are at 3:32 Arizona time. Do I have a motion to adjourn?
I move to adjourn.
Thank you, Henry. Do you have a second?
Second.
Thank you, Beverly. With that, may I have a quick vote? Everyone in favor, say aye.
Hi.
I.
Okay, it's unanimous. Thank you, panelists, for your presentation today. We greatly appreciate it. If you have any additional materials you would like to send for the committee's review, please feel free to email them to Angelica Trevino. You should have her email address. If not, Kayla will send it your way. Thank you so much for your time and your testimony today. We greatly appreciate it.
Yes. Take care.
Thank
Have a
you.
wonderful day.
Thank you.
Thank you all.